Hi, this is Dr. Mimi Lamb, and I would like to help you understand the basic processes by which our bodies regulate volume and osmolality. So what we'll be doing here is first to describe the principles of the two independent systems that regulate extracellular fluid volume, or ECFV, and serum osmolality, and second, to highlight the role of the kidneys in the regulation of ECF volume and osmolality. What you'll see is that ECF volume is basically regulated by changes in renal tubular sodium reabsorption. ECF volume varies up and down all day long, and the things that sense the volume are baroreceptors, or little stretch receptors that sit in strategic points in the circulatory system, mainly in the arterial side, like the aortic arch, the carotid sinuses, the renal afferent arterioles, and there are also some that are located in the great veins of the thorax. These sensors sense whether volume is up or down, and they send messages to the mediators to change renal tubular sodium reabsorption and to adjust volume. The mediators are primarily the renin-angiotensin-aldosterone system, or RAS, and the sympathetic nervous system. So we'll see that the process of volume regulation, even though this does not seem intuitive and is hard to get your head around, the process does not mean that ECF volume is kept constant. The regulation of ECF volume, as we've said, is related to changes in renal sodium reabsorption, and it turns out that the kidney does not maintain a constant volume, but it actually adjusts volume to be proportional to the amount of sodium in the body, depending on sodium intake or losses. And the reason that you want to do this is to prevent water shifts between fluid compartments. So to understand how important this is, let's think about what happens if we suddenly increase the amount of sodium in the body. Here we're talking about body fluid compartments with volume along the x-axis and osmolality along the y. Total body water makes up about 60% of body weight and is divided into two compartments. The largest is intracellular fluid, or ICF, which is about 2/3 of total body water and 40% of body weight, and ECF, or extracellular fluid, which is about 1/3 of total body water, or 20% of body weight. ECF, in turn, is divided into two smaller compartments: plasma volume, which is contained within the blood vessels and makes up about 1/4 of ECF, and interstitial fluid, which is outside the cells, but also outside of the blood vessels. So this is the fluid that is surrounding and bathing the cells, and it's actually 3 times larger than plasma volume. Because the capillaries are fenestrated, small molecules like water and sodium can move freely back and forth across the capillary walls and equilibrate between the plasma and interstitial compartments. While large things like cells, protein-bound substances, and proteins themselves are kept within the vascular space. So 2 things to remember about this. One is that the osmolality of the ECF and ICF spaces is normally the same. The osmoles themselves are of different compositions, but the total osmolality is the same between ICF and ECF compartments, because if it's not, water can shift between the compartments, which is a bad thing, as we'll see. The second thing to remember is that the only compartment that is directly accessible to us is the plasma space. This is the only space that we can directly sample, for instance, by putting a needle into it, and it's the only space that we can add stuff to by either IV or by the person eating something and having it directly absorbed into the gastric capillaries and the circulatory system. In this diagram, I've changed things to fractions of total body water for simplicity. So ICF is 2/3 of total body water, ECF is 1/3, and then the plasma and interstitial fluid are 1/4 and 3/4 of the ECF, respectively. So let's look at what happens if you suddenly add sodium to the ECF. And the way you would do this is to eat something salty, such as potato chips, French fries, Chinese food with soy sauce, or pizza, without drinking any water. What's going to happen if you put sodium into this plasma compartment? Adding pure sodium is not going to change the volume of the plasma compartment, but it is going to increase the osmolality, and that's going to introduce an osmotic disequilibrium between the ECF and ICF compartments, and water will move toward the higher osmolality, so it's going to move into the ECF and shrink the ICF. And this is a bad thing, not too disastrous if we're talking about muscle cells or skin, but if you shrink brain cells, that can be very bad because the brain is tethered to the inside of the skull by the dura mater, and if you shrink the brain, you can cause blood vessels to tear, causing hemorrhage in the brain. So in order to avoid that, there are mechanisms that happen when you ingest salt alone. These mechanisms cause you to retain a proportional amount of water so that the extra osmoles from the salt can be diluted and P-osm doesn't have to change. The plasma volume and the interstitial volume each get a little larger. But osmolality doesn't change, and you don't have to worry about your brain cells shrinking. So let's spend a couple of minutes previewing the steps by which this amazing process happens. How do your kidneys and body protect you from life-threatening changes in P-osm every time you eat something salty? Here's what happens. Sodium enters the ECF, and it's confined there by sodium-potassium ATPase. In other words, every time sodium tries to sneak into cells, it gets kicked right back out by sodium-potassium ATPase. This results in a transient, tiny increase in P-osm of maybe 2 to 4 milliosms per kilo. In other words, enough to go from its normal value of 285 up to 288. But this tiny little increase is enough to stimulate two things: an increase in thirst and an increase in antidiuretic hormone, or ADH, secretion. The thirst causes you to take in water, and meanwhile, the ADH causes an increase in renal tubular water reabsorption in the collecting tubule, returning water from the glomerular filtrate back to the circulation and increasing the size of the ECF. Just enough water is retained to match the amount of sodium eaten and to dilute the slightly high P-osm back down to normal. Then over the next few hours or days, renal sodium and water excretion gradually increase, allowing ECF volume to return back to normal. So think of this as two parts to the response, fast and slow. And the important thing to remember here is that the fast steps protect your osmolality from changing as you gradually absorb the sodium from your stomach, and the fast response occurs over and over as needed. In other words, every time you take a few more bites of pizza and absorb a little more sodium, that response of increased P-osm, increased thirst, increased ADH, increased ECF volume occurs over and over again so that your P-osm never strays more than 1 to 2% from normal. And every time you absorb a little more salt from your stomach and P-osm starts to creep up again, your fast response kicks in and brings it right back down to normal. After the increased sodium intake is over, you are left with a normal P-osm at the expense of a slightly higher ECF volume. Then over the next few hours or days, increased renal sodium water excretion kicks in, gradually bringing the ECF volume back down to normal. And what's involved in the way the kidneys respond to this change in ECF volume? Here we are, having protected our osmolality from changing at the expense of a slightly larger ECF volume, but in the longer term, the baroreceptors are going to sense this higher volume, and the kidneys are going to want to get you back into sodium balance, so they can do that by adjusting things to make renal sodium reabsorption increase or decrease. To increase, we have the big powerful factors like RAS and the sympathetic nervous system, and ADH also works a little. And to decrease sodium reabsorption, we have atrial natriuretic peptide, or ANP, and prostaglandins, which are smaller factors. The most important factors, though, are the activity of RAS and the sympathetic nervous system, which can override all the other weaker players. So in other words, if you want to readjust your sodium reabsorption, you actually do that by either increasing or decreasing the big guys, and it almost doesn't matter what the others do. And so in this case of increased sodium intake and increased ECF volume, you're going to want to decrease RAS and the sympathetic nervous system activity to get rid of that extra sodium. So we've talked about the regulation of ECF volume, and now let's compare what happens with the regulation of osmolality. This is basically accomplished by changes in renal water handling mediated by ADH or AVP. Osmolality, as we've already seen when we talked about sodium, is very tightly regulated to within 1 to 2% of its baseline value. The sensors that let us know that p-osm is out of line and needs to be corrected are osmoreceptors in the hypothalamus, which shrink or swell in response to p-osm and send signals to the pituitary to release or not ADH or AVP into the circulation to go to the renal collecting tubules and do its thing. So we'll turn our attention to how the kidney helps to regulate serum osmolality, which is a much simpler process to understand than volume regulation. But again, the idea is to prevent water shifts between body fluid compartments. Think about what happens when you add water to the body fluid compartments. Again, it's going to go into the plasma space, and it's going to be in the form of just plain water, coffee, Gatorade, Coke, or any number of non-salty liquids. Remember that when you drink these fluids that consist basically of water, a little flavoring, and sugar, the sugar is metabolized and there is no significant contribution to osmolality from these liquids. So it's just as though you are drinking pure water. The result is going to be that the ECF is expanded by the water, which initially stays outside the cells and dilutes the osmoles in the ECF, causing p-osm to decrease a tiny bit, maybe 2 to 3 milliosms per kilo, from something like 285 to 282, so that it's lower than the osmolality of the ICF. So now there's an osmotic disequilibrium that's going to cause water to shift into the cells. Remember that in our previous example, we added sodium to the ECF, causing osmotic disequilibrium and tending to pull water out of the brain cells. And now we're doing the opposite. By adding water to the ECF, we again cause osmotic disequilibrium, and this time we make water tend to shift into the cells, including brain cells. Just as it was a bad idea to make brain cells shrink and pull away from the dura and the skull, now it's a bad idea to make them swell, since they're contained in an inexpansible skull, and you can have disastrous consequences from brain swelling. Now let's look at the steps by which you respond to a water load and the threat of brain swelling. First, by drinking water, you increase your extracellular fluid volume, but more importantly, you decrease your plasma osmolality by as little as 1 to 2%, as we've said, and even this tiny increase is enough to completely suppress the secretion of ADH or antidiuretic hormone, and that causes a decrease in collecting tubule water reabsorption and allows the production very quickly of a large volume of dilute urine, which then gets rid of this extra water and returns both ECF volume and p-osm back to normal. And so returning to our diagram, the way the kidneys help you to handle this situation and keep you safe from osmotic disequilibrium and brain cell swelling is that they very quickly, as soon as osmolality starts to fall a tiny bit, help you to get rid of the excess water before it can cause a significant or lasting fall in osmolality. Again, with the result that you don't have any change in the size of your brain. In summary, the way the body handles an increase in the intake of sodium versus water is like this. With an increase in sodium intake, there's a tiny increase in p-osm, causing the body to retain water via mechanisms of thirst and ADH, with the amount of water retained exactly balancing the amount of sodium retained, such that ECF volume increases, but p-osm doesn't change, and so no water shifts between ICF and ECF. Then over the next few hours or days, the extra water and sodium is slowly excreted to return ECF volume back to normal. In contrast, an increase in water intake results in rapid suppression of ADH to keep p-osm constant and to prevent water shifts. Note that in both types of regulation, water shifts are prevented and so is damage to the brain cells. Notice that volume regulation by changing renal sodium reabsorption is a much more sluggish response than osmolar regulation by changing water reabsorption, which presumably is because there are so many steps and neurohormonal pathways involved in changing sodium reabsorption, while with water reabsorption, it's just ADH on or ADH off. But you don't have to worry about that temporary extra volume that you acquire after you eat salt, because a normal person can accommodate changes in volume just by adjusting the tone of their arterial vessels to keep blood pressure normal. And in the short term, even with changes in sodium intake, it's the quick mechanisms involving ADH that keep your piasm from changing, while the body activates the more complicated pathways to eventually get rid of the extra sodium and return volume back to baseline. So just remember that the body can accommodate changes in ECF volume, no problem, but it cannot tolerate changes in osmolality, which can quickly become deadly if osmolality changes too much in either direction. And the final question is, how are you as a person going to know that these regulatory mechanisms are happening and that everything is working the way it should? If you eat something salty, you'll notice that as your piasm rises, you get thirsty, and that despite drinking a lot, you don't seem to have to go to the bathroom very much, and you may notice an increase in your weight the next day. That's your body requesting and retaining the extra water to match the extra sodium and making new ECF to keep piasm from changing and to prevent water from shifting out of your brain. And if you drink a bunch of water, you'll notice that you have to go to the bathroom very soon after that and that you produce lots of very dilute-looking urine. That's your kidneys responding to the lower piasm by turning off ADH and getting rid of the extra water so that your piasm can come back up to normal to prevent water from shifting into your brain. So those are the basics of volume and osmolar regulation, and now it's up to you to fill in details with reading. So think about these, read more about the receptors and hormones and pathways that allow regulation to work, and once you understand the basics, you'll be in good shape to understand the various diseases and disorders that can disrupt these complex and elegant processes and what the consequences of these disruptions are. So if you have questions as you study, please feel free to email me or send comments, and I hope that this video has helped your understanding.